Today's topic is entitled Abdominal Sepsis, and our outline we're going to talk about today, we're going to talk about abdominal sepsis. Usually in the literature, it's what we're talking about is called intra-abdominal infection, and not abdominal sepsis, although that tends to be a surgeon's term. The literature usually, particularly for infectious disease, tends to be intra-abdominal infection. We'll talk about how much of a problem it is in the hospital, some of the questions and controversies about it, and what the antimicrobial regimens are for this. So you won't be doing general surgery very long before you start getting cases where you've got nasty abdomens and pus and patients who've got significant intra-abdominal infection, and the therapy of these infections is it's a common problem, and the therapy of these infections is very important because it is frequently life-saving if it's done correctly in internal time. The definition: well, we have intra-abdominal infections, and we have what are called complicated intra-abdominal infections, and basically what we're talking about is an infection that goes beyond the hollow viscus into the peritoneal space. And usually when that happens, there's either an abscess or peritonitis, which is evidence of bacterial infection inside the peritoneal space. Because these are, by definition, a surgical infection, that means that they are either the result of surgery or require surgery, which can be the form of either surgery or percutaneous intervention to control them. This is the stock and trade on white surgery and an acute general surgery. It includes things like, these sound familiar, perforated gastroduodenal ulcers, biliary tract infections, small bowel perforations, complicated appendicitis when there's an abscess or perforation, and complicated diverticulitis with an abscess or perforation. So this is essentially the stock and trade in acute general surgery. So how big a problem is a paper by Phil Berry in 2004. It looked at 465 patients from a major New York City hospital over about a 10-year period who had viscous perforation. They either had peritonitis or abscess. In terms of the bacteria that were growing in their peritoneum, 72% had community-acquired bacteria, 28% had hospital-acquired bacteria. 3/4 of them had some form of organ dysfunction, which means that they would usually meet the criteria of what is called severe sepsis. And there was a 23% mortality, which is pretty significant. It's almost 1 in 4 of these patients will die. I'm talking about patients who basically get infection secondary to a perforation in the GI tract somewhere. So normally in the gut we've got our bacteria, and they're depending on where you are in the GI tract, there may be a few or a lot of bacteria. The stomach and particularly the proximal small intestine doesn't have a lot of bacteria, usually less than 1,000 colonies per ml, and they tend to be things that are resistant to acid, like lactobacilli, Candida, and whatnot. Then when you get into the colon, of course, you're going to have a lot of bacteria, 10 to the 12 per ml or gram, and almost all of it's anaerobes. Almost every bit of that is anaerobe. Bacteroides, Eubacterium, Bifidobacterium, Clostridium, and there's a few aerobes, but still a fair amount, but not as much percentage-wise, and they're E. coli, Enterobacter, and whatnot. Now, this will change in somebody who's been chronically ill or who's been on PPIs. If they've been on, say, Protonix or something like that, what's going to happen is you're going to have oral bacteria and colon bacteria in parts of the GI tract that are not normally found, like in the stomach and the proximal and small intestine. So a patient who's been in a hospital for a while, a patient who's been on PPIs, patients with chronic illnesses, they'll have different gut bacteria. You can also occasionally get bacteria on the outside of the bowel as a result of bacterial peritonitis, or sometimes after secondary peritonitis, and those are things like Staph aureus and Neisseria and TB, but those are pretty unusual, not usually something we worry about in the scenarios that we're talking about. So what happens in terms of the disease and what the pathogens are? Inside the GI tract, you might have 300 to 500 species of bacteria as the normal flora. and then something happens where you get contamination in the peritoneum, where that GI flora gets into the peritoneal space. And as a result of things like host defense, how much oxygen's out there, the virulence factor of the bacteria, and how things are actually cultured, what will actually cause the contamination and infection will be much fewer bacteria. So you'll typically, in an intra-abdominal infection, you'll only culture typically a couple of anaerobes and maybe 2 or 3 anaerobes when you started out with maybe 500 bacteria. And that's kind of the process by which the contamination goes on to becoming infection. So you get a paring down of the pathogens to a very few. So how does the pathogenesis occur? They've done various studies using animal models trying to mimic what happens in intra-abdominal infection, and they'll do typical things like put a gelatin capsule filled with rat feces inside the peritoneal cavity of a rat, and if they get peritonitis from that, there's about over 1/3 of those animals will die. If they survive, every animal got an abscess. So those are sort of the 2 major pathways of intra-abdominal infection. You can get peritonitis, and that may be followed by an abscess, or you may just get an abscess. In trying to look at different antibiotics in terms of what will happen, you'll see that different antibiotics will change what will happen. And if you use gentamicin, your mortality goes down, but you still see a lot of abscesses. If you use clindamycin, mortality doesn't change, but abscess rates become much lower. And if you use the 2 before together, you get a low rate of mortality and abscess. So that's one of the first things we know about in dealing with intra-abdominal infection. We have to cover all the bacteria that are there. The aerobic bacteria, the gram-negatives, are more likely to be associated with peritonitis, sepsis, and death, whereas the anaerobes seem to be necessary for an abscess to form. And there's another way of looking at that. So putting in feces into the mouse or rat, giving them peritonitis, they all get a little bit of bacteremia, usually E. coli. In this particular study, about 40% of the animals died at 5 days, and in those that survived, which is a little over half, they all got abscesses. So here's a typical menu of bacteria that will be found in intra-abdominal infections. And you can see that for the most part, E. coli is the big player, but you get contributions from other bacteria like Klebsiella and Pseudomonas, Proteus a little bit. On the gram-positive side, Streptococcus species are often found. Enterococcus is an issue, and we'll talk more about Enterococcus towards the end of the talk. And of course, the anaerobes are there as well, particularly Bacteroides. They by far are the most common ones, but Clostridia can be in there as well, and it's an important infection when it occurs. So what's the best initial antibiotic regimen for somebody who's got an intra-abdominal infection? Well, I would advocate that the best antibiotic is steel. That is the best antibiotic of all. If you can separate the patient from their infection, that's obviously the best way of treating it, because if you can extirpate the infection, that gets rid of it. You can't always do that, but you can certainly get rid of a lot of the infected material, control the contamination, stop further infection, debride dead, necrotic, and infected tissue. So that's always the first part of treatment. Now, that's not the whole thing, but this is sometimes, particularly for our non-surgical colleagues, not their first line of therapy. And if you see somebody with an abscess, they need to have an abscess drained. One of the oldest sayings in medicine: if there is pus, let it out. Pus is one of the ways the body tries to get rid of an infection. So if you can get rid of that pus, you do a lot to making that patient getting better. So therapeutic principles, intra-abdominal infections, surgery, and antibiotics. For surgery, the goals are things like decompressing the bowels, particularly if you're dealing with an obstruction or you've got a lot of colon or small bowel content proximal to a site of perforation. Trying to get that bowel back in one piece so it's not leaking into the peritoneal cavity anymore. If there's anatomic abnormalities, things that are likely to cause strictures or obstruction, which may cause your repair to break down, create fistulas, you want to deal with those. If there's a lot of bacteria in the area, you want to clean that out, and that may require debridement of tissue, removal of infected or dead tissue, and draining that as well. Removing what's called adjuvants and cytokines, that's basically anything around that may be making things worse, which could, usually that we're talking about dead or ischemic tissue, and draining abscesses. Now there are some things in abdomen that don't require surgery, and those are the topics we're not talking about today, which is spontaneous bacterial peritonitis. Pelvic inflammatory disease is a little bit different because that's not usually gram-negatives, although it can be. It's usually things like Neisseria, which is a surface bacteria, and it's treated differently. And of course, peritonitis from peritoneal dialysis is treated differently as well. And of course, there is an alternative to surgery, which is percutaneous drainage, which can be basically is a form of surgery where you don't have to make a big incision, but you still get that pus out. And that may be a therapy as well. Antibiotics are the other part, and I'll talk about that later in the talk. Percutaneous drainage. When should you try to drain an abscess percutaneously? This is a paper from two papers that looked at what's required to get it done. Generally, you want to have a limited number of abscesses. If you tell the radiologist that you've got 42 abscesses you want him to drain, he's going to tell you you're nuts. You can't do that. You want to have ideally 3 or less, because that's generally what's doable and what the patient will tolerate and what can be seen and done in a reasonable session. So ideally, the abscesses should be unilocular. If you're looking at an abscess and it's all full of loculations and there's septa in there, or it's in between loops of bowel they're just not going to be able to drain that for you, because what the radiologist is going to do is put a needle in there and then put a catheter in that spot. What you can do with your finger is you can stick your finger in an abscess, break it down, scoop out any contents, clean it up, and that'll make it a lot better. It has to be a safe approach. So if you ask for him to go through it through a vascular area, through the mesentery, he's not going to want to do that. It has to be reasonable, something that will come out of a catheter. So if it's filled with solid material or a lot of hard feces or stuff like that, it's not going to come out very well. It works best in things like liver abscesses and around the appendix. Appendiceal abscesses usually work pretty well because they tend to have a nice capsule of something they can perforate and tend to be unilocular. A little tougher on postoperative abscesses because they usually tend to have bowel nearby, and often they're in loops of bowel, so it's tough to get at. Diverticular abscesses can also be tough for the same reason. And one of the tougher ones to get for abscesses is actually the pancreas, because pancreas is a lot of vessels and stuff in the way that may be tough to get at. But depending on what kind of abscess it is, postoperative abscesses generally do pretty well. If they get into it, that's usually all that's required. So we had a patient recently who had a splenectomy, came back to clinic about a week after a splenectomy with fevers and chills and a little bit of right upper quadrant pain, suspected an abscess or an pneumonia. Did a CT scan, had an abscess. Percutaneous drain went in there, pus came out. Only 25 cc's, but the patient got immediately better. His white count fever went away, and he was home within a couple of days of that. So that's the best sort of outcomes you get. Another thing to remember about treating abscesses is, this is from a paper by Rivers. Can anybody summarize Manny Rivers' paper, what it's about? And so one interpretation of this paper is having specific goals, but what was the other big difference between the two groups in terms of the two groups in this paper? You had one group that had specific goals and other that didn't have any specific goals, but other than resuscitation in general. But what else was different about these two different groups?
Early intervention and treatment with the ER to get them.
Right, so one group was left in the ED, and there was no time to send no specific time that the patient had to reach the ICU. The other group was supposed to get into critical care very quickly. So to surgeons, this paper is kind of a no-brainer, because we know that when our patients are septic, they need to be resuscitated quickly, and then once you've got them resuscitated, source control and antibiotics are the mainstays of treatment. So the thing is, with abdominal sepsis, if it gets sat on or if it's missed and the patient lingers, and this sometimes happens, and you'll see that the outcomes are much worse. The mortality is significantly increased. So Doesn't have to be pneumonia. This is true for abdominal sepsis as well. So one of the things about it, if you suspect abdominal sepsis, you have to be aggressive in working that up and treating it, because if you sit on it or you miss it, that patient's going to have a much worse outcome as a result. This is looking at choosing the right antibiotic. We're going to start talking about antibiotics a little bit here. This is 406 different septic patients. This included abdominal sepsis as well as pneumonia and some other infections as well. But choice of the antibiotic up front is also important. If you choose the wrong antibiotic, it can triple the mortality. And this is looking at whether or not they got appropriate empiric antibiotics after they got, before they got their cultures, and then comparing them with the cultures they actually had. And you can see that there's a significant difference in outcomes depending on whether or not they got their correct antibiotics or not. Everybody ever heard of the drug called Zygris? I can't even say it. Drogotrogan alpha. In that use of that drug in surgical patients, that drug only works if the patient had inappropriate antibiotics selected. If the patient had appropriate antibiotic therapy, empiric antibiotics, the effectiveness of that drug is essentially zero over regular therapy. So who needs to get antibiotics? Well, we've got to talk first about what the difference is in abdominal sepsis or severe intra-abdominal infections versus patients who are getting prophylaxis. So when you take out an appendix and you give that patient antibiotics post-op, is that therapy? Really isn't. I mean, it's really probably a continuation of prophylaxis. And what are you prophylaxing against when you give somebody antibiotics after appendectomy for 24 hours? It's basically you're trying to continue your prophylaxis for wound infection. What's the evidence for that? The evidence for post-operative wound prophylaxis is pretty poor, but we often do it. So for these groups of patients, groups like the Surgical Infection Society and ISDA and their guidelines, they say that patients who have bowel injuries repair within 12 hours, patients who've got acute appendicitis without any bad features like gangrene, perforation, abscess, or peritonitis, or if you've got an acute perforation in the stomach, duodenum, or proximal GI tract, and they don't have malignancy, and they weren't on a antacid therapy like PPI or H2 blocker, those patients just need to have 24 hours antibiotics, and that's it. So you're continuing prophylaxis. But they don't need treatment against abscess and peritonitis because presumably they didn't have peritonitis or abscess to begin with. So that's a little bit different. So we're not talking about that group of patients, okay? That's different stuff. Another group of patients who often get antibiotics where it may not be indicated as acute cholecystitis. Most patients who've got acute cholecystitis, at least in the first few days, don't really have infection. It's only if you really suspect antibiotic infection is present that you need to give them something on a persistent basis. And if you do give them something, it just needs to be against gram-negative rods. There's a lot of concern about Enterococcus. I'll talk about that later, but it's not usually a problem in gallbladders. There's no need to treat anaerobes. You don't have to get cholecystitis patients flagyl unless you've done something kinky like a cholecystogenostomy or something like that. So, another controversial area is treating infected pancreatic necrosis. Does antibiotics reduce the risk of infected pancreatic necrosis and pancreatitis? This is a question. When you're treating with pancreatitis patients a lot, this is a question that comes up very frequently. What should you do? Patient's got severe pancreatitis, big edematous pancreas. They're sick. They are on the ventilator. They have a fever. They have a white count. CT scan doesn't show any abscesses. Cultures have all been negative. Should they get antibiotics? It's one of the more controversial areas in looking after these patients. Generally speaking, often surgeons and gastroenterologists will say, yeah, give them antibiotics. And infectious disease specialists will sometimes say, no, don't give them antibiotics. Or sometimes it's vice versa, depending where you are. But generally speaking, the literature doesn't seem to support prophylactic antibiotics in severe pancreatitis. Although there are some papers out there that seem to suggest that it decreases the risk of complications. But So, high-risk patients. These patients are patients you probably should be thinking about broad-spectrum antibiotics and choosing an empiric therapy that's going to cover a broader spectrum. So, patients who come in with high Apache scores. So, what's an Apache score? Anybody? So basically, it's age, type of illness, and their physiology that they have particularly on the first day in the ICU. So high Apache score means somebody who's basically sick, old or older. Sometimes will make it higher, and patients got severe illnesses. Nutrition is very important. Patients who've got cardiovascular disease, that's an issue. If you have a patient whom you cannot control the source because you can't get at it, or you can't drain it, or can't operate on it, you've got to think about broad spectrum empiric therapy. If they're immunosuppressed, either by therapy or by their condition, that's a problem. So patients with dialysis or leukemia, patients with HIV. If they've had a prolonged preoperative stay, why would that be an issue? Yeah, anybody who's been in the hospital for a while starts to pick up new bugs, and that changes what is likely to grow out. And if they've had prolonged preoperative antimicrobials, so that can also be selecting them for more resistant organisms. So, when should we do cultures? Intra-abdominal infections. Should we culture every patient with peritonitis, every abscess, every patient with appendicitis? Should they all have cultures done every single time? Or is that too much? When's it going to help you? Well, for certain infections, you have a pretty good chance of, you only want to do cultures when it's likely that it's going to influence your therapy. It's going to change your therapy. So for routine appendicitis, what's likely going to happen if you culture that appendix? What's going to be growing there usually? Who votes for gram-negatives? Okay. How about anaerobes? Could be anaerobes. Right. Likely to change your therapy? Not if you got the appendix out and it was not a big deal, right? So, uncomplicated perforated or gangrenous appendix, if there's no abscess, it doesn't change the outcome if you don't, whether you do cultures or not. So, cultures aren't required for those cases. If there's an abscess, you do need one. If you have an abscess, pericolonic infections, if you're more likely to have a failure if you don't use anaerobic coverage for those patients. So that's important. So if you're going to culture somebody who's got a pericolonic infection, pericolonic abscess, how are you going to culture that patient? What are you going to ask the nurse for in the OR? Yeah, right. You want the proper transport type swabs. If you just do a regular cotton swab and throw it into a bag or something like that, it's not going to work. So you need that. If you're dealing with an unusual community, say somebody has just got off the boat and they spent the last 3-4 weeks in South America, and now they're coming in with rip roaring peritonitis and abscess and diverticulitis. That patient may have different bacteria than we're used to, so it may be worth a patient who's got that sort of thing. Particularly, that may change their community. For anaerobes, generally, metronidazole or flagyl will zap most of them. There's not too many that it won't get. If you're using imipenem or meropenem, that'll also zap them pretty good. Or if you're using something like Zosyn, which has got a powerful beta-lactam inhibitor along with the tigercillin, that'll work pretty well too. But if you're using something like clindamycin or one of the other anaerobic drugs, or you're hoping that a fluoroquinolone is going to kill the anaerobes, that's a good reason to do a culture. Generally, in these patients, it's easier to use flagyl than to try to make those drugs work. And of course, if you have a problem with an ongoing suspicion or evidence of anaerobic infection, of course, then you'd want to get cultures as well. So, what are healthcare-associated infections? Or HAIs are also often called nosocomial infection. These are infections that occur after the initial operation. So, somebody comes in, they have an operation, and then they get their intra-abdominal infection. Maybe it's a hernia repair that went bad. Maybe it's a bowel anastomosis that leaked or something like that. If they get their infection in the hospital, they're much more likely to have healthcare-associated infection, much more likely to have resistant organisms. And therefore, you've got to think about those bugs as well and cover them. So that generally means you've got to be thinking about things like MRSA, VRE, and multi-drug resistant gram-negative ROS. We've had issues here with extended spectrum beta-lactamase E. coli, which is a little tougher to get rid of. And so what grows out depends on where it happened. So if the patient got their intra-abdominal infection in the community, it's likely going to be bacteria on the top there. It's going to be enteric gram-negative bacteria, the facultative bacilli, the beta-lactam susceptible gram-positive cocci, and the anaerobic bacilli when you're dealing with distal infections. So E. coli, Klebsiella, Bacteroides, those are the likely things we're going to see. But if it's going to be a healthcare-associated infection, post-op or nosocomial, that means patients who are in for a preoperative length of stay or they got more than 2 days antibiotics, you have much greater chance of growing out things like Pseudomonas, Enterobacter, Proteus, MRSA, Enterococci. And so you need to know what's likely to grow, and you need to know what the susceptibility in your local hospital actually is. So how do we do that? The antibiogram. Very good. The antibiogram. So the antibiogram tells you for any particular bacteria that's been cultured in our hospital what the sensitivities are. If you're writing prescriptions for antibiotics for patients in the hospital, you must take a look at the antibiogram. Otherwise, you don't know whether or not the antibiotic you're prescribing is going to be effective. In terms of what should be cultured, if you're dealing with an intra-abdominal infection, what you want to culture is the abdominal abscess or the peritonitis. The blood cultures may or may not be growing out what the patient actually has, particularly when the patient becomes complicated or in the ICU, because what's growing out of their blood may be from something else. Could be from the line or from pneumonia, or more likely than not, an awful lot of intra-abdominal infections never have a positive blood culture, because there's a big filter between the abdomen and the bloodstream that sometimes stops a lot of that, called the liver. So a lot of that stuff doesn't get out sometimes. If you are going to do an intra-abdominal culture, you got to get something that's representative of the process. So you want to get into that abscess and get a good piece of it. 1 or 2 cultures, you usually do it. Make sure you always send anaerobic as well as routine, and we always use the right type of culture. What about gram stains? Gram stains aren't usually necessary for community-acquired intra-abdominal infection because it's going to be probably what you think it is, gram-negatives and anaerobes. If you have a healthcare-associated infection and you're not sure, you can do gram stains, particularly if you worry that the patient may have gotten gram-positives. How does a patient get gram-positive cocci in the abdomen? In our scenario for our service. Not very common, but sometimes it happens. Which kind of patient gets that? Yep. Well, remember, staph kind of a surface bug, so what do they need? Basically, these patients with open abdomens and large open wounds, infected hernias, and things like that. So those patients are more likely to have MRSA. Fungus. When do we have to treat for fungus? Generally, it's not really needed for most patients, except if they have recent history of immunosuppression therapy or they're immunosuppressed by their disease, or if it is a post-op intra-abdominal infection. So you've operated on them, they've had a leak or something like that. Those patients are in the hospital and they're more likely to have fungus. Patients coming out of the community are not very likely to have fungus if they are immune competent. And what therapy do we use? If you're dealing with Candida albicans and you know that's what it is, we tend to use the imidazoles such as fluconazole. But if you're not sure, or a patient's immunosuppressed, or they've been in the hospital for a while, there's a very good chance it's not going to be albicans. It's going to be one of the other Candida, like glabrata, or there's a whole bunch of them. But in those cases, we'll tend to use the broader spectrum antifungals like casifungin, voriconazole, and amphotericin. When do you have to treat candidiasis. Let's say you've done a culture or you know that there's Candida in there, and very frequently it grows out in combination with bacteria. So you'll get a culture, comes back, it'll say 10 to the 5 or 10 to the 6 E. coli and Candida. You have to treat the Candida. Well, there's sort of two sort of schools about that. One was if you saw a clinical infection, if you saw a Candida and the amount of Candida was a large amount, or if it was increasing, that was considered to be evidence of infection. But there's a later paper from 2006 that says that Candida actually is a risk factor for mortality, so maybe a marker of a patient who's actually not doing very well with their infection, but antifungal therapy didn't change the outcome, which may be a sign that when you see fungus growing out in the culture, the patient's got a bad infection and they're in a high mortality group, but actually therapy of that may not change very much. Generally speaking, though, if you see it in a culture, we definitely will treat it, but empiric antifungal therapy probably should be reserved for patients who you suspect have got post-op infections. Now, Enterococci. Do we have to treat for Enterococcus? And this is always an issue because what sort of antibiotics are useful against Enterococcus? Always comes up on exams and quizzes and the old Enterococcus. So what do you use against Enterococcus? One antibiotic is used good against it. Vanco will work, particularly if it's VRE. Yeah. What if it's not VRE? Just regular old Enterococcus. Ampicillin works against it pretty well as well. So the interesting thing is that in experimental animals, when you do this, it's always there. So when you put some feces in the rat abdomen and check later, you'll get Enterococci. But it doesn't seem to have any role in mortality. The gram-negatives seem to be more important than that than the Enterococci. And the interesting thing is that to get an abscess, Enterococci has to get along, make a partnership with anaerobes. But if you've got a lot of Enterococci and E. coli gram-negatives, that doesn't tend to form abscesses. Again, looking at rats, if there's a lot of Enterococcus in there, it tends to make the animals sick. It tends to cause more weight loss and a higher rate of bacteremia. And Enterococci really tend to screw up the leukocytes more in the animal, so you get more resistance to intracellular killing, and may also have a pro-inflammatory role. So there's a lot of people who believe that there's a synergistic effect of Enterococci. Looking at a study of patients getting treated with ciprofloxacin, metronidazole versus imipenem, if they had Enterococcus in the initial culture, it was a predictor of treatment failure, but not as much as the Apache score was. And about 20% of the cultures in these patients had Enterococcus, and the risk factors for Enterococcus are age, Apache 2, and length of hospital stay. So Enterococcus, it has a role as a pathogen, but it may also be important as a marker. If you have Enterococcus in the culture, that may be a sign the patient's been in the hospital for a while, they're older, they're sicker, and that may be important as well. There have been 6 different trials. This is from the IDSA, and it shows that there's been no advantage of adding Enterococcus coverage for patients with community-acquired infections. That's level 1 evidence. So you don't have to give AMP, Gent, and Flagyl. Remember that therapy for community-acquired infections, or you don't have to treat Enterococci for the community-acquired patients at all. Patients who are in the hospital, you might have to think about it. And of course, if you recover it, they suggest you treat it, but that's level B3, not quite as strong evidence for that. So, indications for it: not required for community-acquired infections. Indicated if you actually culture it, or if you see it in the blood. So if you get Enterococcus in the blood, that's an issue. Interestingly, most of the Enterococcus in the blood that we see in our ICU is not from the abdominal infection. It's usually a sign of line infection, because that's actually one of our #1 pathogens for central line infection. So this is the antibiogram that Julie told us about. So Julia, where would you find this?
Kevin.
Kevin, it's a very good place to go. Kevin, if you talk to Kevin Box in the ICU, he'll have it on a piece of paper, which is convenient, and it gets updated on a quarterly basis. So, where else could you find it? Say you couldn't find Kevin, but you wanted to know.
No, on the homepage of the
So you go to the home page. Okay, there's the home page, and then you go up to here, infection control, epidemiology unit, and you click on that. And when you click on that, you get this page. And if you go down this page and scroll down the side, you'll see antibiotigrams. You click on that, and then inside there you'll find the most recent antibiogram. So, and if you look at them, you know, it is interesting. For instance, this is too small to read, so I'll show you this slide instead. This is also on that page. So how much of our staff is MRSA in this hospital? 50-50 right now, right? And it's getting worse. So it's heading for the point that most of our staff may become MRSA. Only 14% of our enterococci is VRE. So it's not always VRE that you're growing out. Strep pneumoniae is not so interesting to us usually. Pseudomonas, about 43% is resistant to ciprofloxacin, 18% to piperacillin, and 21% ceftazidime. So we haven't mandated double therapy for Pseudomonas, but you can see that why some people would find that attractive. You can see that there's, depending on which drug you use, for instance, Zocin, you got about an 18% chance you may be resistant. So our Acinetobacter last quarter, none of it was sensitive to Zocin. 29% only to Cipro, and 33% to Bactrim. Meropenem is the best antibiotic for that right now, but it's still only effective in about 70% of them. So it's all there, and you can look that up. So let's talk about some of the antibiotics you could use, and I'll talk. There's basically two great sources of data about this. One is the Infectious Disease Society of America practice guidelines, which is what most people use. That hasn't been updated since 2003, and it is about to be updated this year. So there'll be new 2009 guidelines coming out sometime, which will be interesting because probably what they're going to do is they're going to deal with a couple new antibiotics that have come out. The reason they haven't had to be updated in 6 years is that, unfortunately, there has not been any new wave of antibiotics to deal with these infections. The only two antibiotics that are new are tigecycline and moxifloxacin. And I'll talk a little about those, but first we'll talk about the standard antibiotics. So this is the recommended guidelines for these. You've got single agent regimens or combination regimens, and then you've got mild to moderate infections versus high severity infections. So ampicillin sulbactam, also known as Unison, it's a single agent for mild to moderate. Ticracillin clavulanic acid is Timentin. Vertipenem is known as Invans. We don't use any of these antibiotics in our ICU. For high severity infections, piperacillin tazobactam, which is Zocin, imipenem cilastatin, and meropenem are options. We don't use this imipenem very much. We do have meropenem, and we do have Zocin. Combination therapy. Combination therapies have not been shown to be any more effective than the single agents, but they are available. And particularly for mild and moderate infections, my favorite a lot of times is cefazolin and metronidazole. So for patients, I'm giving a couple doses of antibiotics after appendectomy for 24 hours. That could be an adequate choice. You can also use a fluoroquinolone along with ciproflagyl in those as well. They're also been shown they can also be used in high severity infections, but generally speaking, when I have somebody who's got a complicated intra-abdominal infections, I tend to use Zocin or possibly meropenem in those patients. There is with Unison, there are some, you do have to check your local antibiogram because the drug has become less popular because there's more resistance to it as well. And the same thing with metronidazole and the fluoroquinolone use. There is increasing resistance to that regimen as well. Talk about some of the other drugs, the newer ones that have come out since the guidelines. Moxifloxacin is a fluoroquinolone, and it's been advocated as a single once-a-day dose, 400 milligram dose of it. And there was a study that was done versus Piptazo or clavulin in the United States, Canada, and Israel. And basically, patients who had an intra-abdominal infection that required either surgery or percutaneous drainage, and they were treated 5 to 14 days. They either got this IV or PO, which is one of the attractiveness of moxifloxacin. You can give it IV or PO, whereas the Piptazo, you had to give that as Zosyn IV, then you had to switch to clavulin post-op. And looking at their primary endpoint, which was clinical response, there is the same. The trial basically shows non-inferiority, which is that this drug for these patients was just as effective. The other drug that's around is tigecycline, and you'll hear about this sometimes. It's a drug that's usually controlled by infectious diseases, but it has there have been 2 phase 3 studies looking at this, comparing it to imipenem in a fairly large sample. This was the previous study, moxifloxacin. There were about 300 patients, 340 patients in both groups. This is a larger set of patients for tigecycline. I'm sorry about the small, but basically the thing that's important here is that non-inferiority. So essentially as effective as imipenem for intra-abdominal infections. And depending on whether it was appendicitis, cholecystitis, an abscess, perforation, diverticulitis, gastric, or just peritonitis or bacteremia, again, no real big differences between the two. So it was basically as effective as imipenem. There are some problems, though, with using these newer drugs. One, for moxifloxacin, it is a fluoroquinolone, and every fluoroquinolone so far has had pretty rapid emergence of resistance, like ciprofloxacin. So this is an attractive antibiotic, but it is expensive, and although it does have an oral form as well as an IV form, there's only been the one study, and so that's always a little bit worrisome. Tigecycline, an interesting antibiotic as well. Most of the patients I've given it to IV who have been awake and conscious have got nausea with it, and that can be a limiting factor. So the literature says 44%. For me, it's like close to 100% when they're awake. Of course, if they're unconscious or in coma, it doesn't matter so much. But that's a pretty common side effect with tigecycline. How long to give antibiotic therapy for? This is one of my pet peeves. For clean contaminated surgery, this is not really therapy. This is really an extension of your prophylaxis, so 24 hours is fine. If you think that there's recent perforation or local peritonitis, some people will call this preemptive therapy, and they might just use 48 hours of therapy. Again, there's not a lot of literature for this. It's just what some people do. If you do, however, have an established infection, 5 to 10 days is considered to be adequate therapy, and you can take your pick of 5, 7, or 10 in there. And of course, if you have the worst of all situations in which you have an established infection and you cannot get source control, you can't operate on them or you can't drain it, well, those patients need prolonged therapy, because that's all you've got. Now, I'm talking about adults. If you're going into the world of children, this is quite a lot different. So we're talking adults here. And kids are not like adults in that kids can get rid of intra-abdominal infections fairly quickly with antibiotics alone, but that's a whole other topic. So now, the Infectious Disease Society of America says you should keep that therapy going until the symptoms go away and the white count and temperature are gone. And this is what I advocate for my patients, even though it's annoying because the patient may look pretty good, but if they still have a fever or white count and they had an abscess or peritonitis, you got to keep treating them until that white count or that fever go away. And there's some old papers that looked at this. So there was one paper that showed 51 patients, if you stopped the antibiotics while their white count was still above 10, 1/3 of those patients came back with a recurrent infection. Or if you waited before the white count was less than 10, 0%. And a more recent, another older paper from that period, looking at meta-analysis of 2,500 patients, 11 different trials. If you stopped the antibiotics when the white count was normal and the patient was afebrile, the the recurrence rate was 3%. If you waited until the white count was normal and the differential was normal and they were afebrile, the recurrent infection rate was 0%. So you may not want to go that far, but certainly if you have a patient who has had peritonitis or an abscess and they have a white count or fever, don't send them home until you've got that under control. I prefer to treat them IV. Now you could argue you could treat them with PO antibiotics, but then the question is, how do you know when the white count and fever have gone away because you've sent them home? So the IDSA says that those patients should be treated until the clinical signs resolve. They have a normal temperature, normal white count. There is some literature suggesting that even the CRP could be used, but there's no study of that yet. And they have, of course, the GI function returning. What do you do if somebody is not getting better and they're 5 to 7 days after their surgery and you think they may have an intra-abdominal infection that's recurrent? That's the point at which you do imaging. So doing it before then, before 5 days, why don't you want to image somebody after intra-abdominal infection before 5 days? Say you've done your source control operation, you're sure your antibiotics are therapeutic, yet they're not quite getting better yet. When do you want to do that CT? Day 3? Why not day 3?
Very few abscesses that are
Right. So you're waiting for that. You're waiting for the recurrent infection, which is probably after peritonitis is likely going to be an abscess, and after an abscess, the likely recurrent infection is going to be an abscess. So what you're looking for is an abscess, and if you've broken down that abscess or gotten rid of the peritonitis in the first operation, it's usually going to start showing up around 5 to 7 days. Typically where you haven't put your drains, because that's why it's there. You can't drain the peritoneum very well, so if you have got recurrent infection, 5 to 7 days. And so now if you do that scan and the patient's doing well and you don't see an abscess and they're otherwise resolved, you don't have to keep treating them. Of course, we're talking a lot about antibiotics and talk a bit about surgery, but the other thing you have to think about, of course, is the rest of the care of the patient. So a patient who has got serious intra-abdominal infection is usually going to have a significant problem with nutrition, because if they didn't have bad nutrition before they got the illness, they're definitely going to have bad nutrition problems afterwards. So there are plenty of animal studies done. This is a very common study done as a resident to feed animals and check colonic anastomosis strength, or tension strength, or burst strength. And you can, it's been shown multiple times in animal studies that if you feed them early, they have better anastomoses that heal, that are stronger. However, you have to remember that in patients who've got significant or bad intra-abdominal infections, that you may not be able to feed them enterally, and you may have to bail out to TPN in those patients. Even though TPN has a higher complication rate, you have to at some point make a decision that you're not going to get them fed enterally, you're going to start them on TPN. And that may particularly have a patient who's got discontinuity or open abdomen. Simple things too. Keeping the patient warm intraoperatively actually has been shown to reduce transfusion requirements and decrease the rate of surgical site infections. So just good patient care is important too. So keeping the patient oxygenated, keeping them well hydrated, keeping them resuscitated, correcting their acidosis, getting rid of their hypothermia, all those things are important as well. Any questions about intra-abdominal infections, abdominal sepsis? It's a huge topic. I mean, you could do a whole residency or fellowship just on this topic alone. But anyway, we're looking with a new. Keep an eye out for the new guidelines. I suspect what they're going to do is they may or may not incorporate the new antibiotics, and they may discontinue some of the older antibiotics like Unison because they're showing increasing resistance. So the problem we have, of course, with this topic is that the resistance and resistant organisms are growing faster than our rate of new antibiotics are. So we've only had 2 new antibiotics for intra-abdominal infection since 2003. So, but we've had a lot of increase in resistance in various organisms as well. So, all right, to summarize, intra-abdominal infections are associated with high morbidity and mortality. Source control plus antibiotics are the main therapy. There is a predictable pattern of pathogens, and so you can pretty much guess what's going to be growing in there for any typical abdominal catastrophe you're likely to encounter. And your empiric therapy is going to be guided by that, and of course by your antibiogram. So you need to know your local antibiogram before you start empiric therapy. And remember that fungus and enterococci are not likely in community-acquired infections, but they can be a consideration in patients who have been in the hospital for a while or have post-operative infections. All right, thanks.
Thank you.